Well, good afternoon. I'm Dr. Montgomery. We may have met before in some of the other talks, either here or previous. And this afternoon, I'm going to speak on the use of integrating plant-based diet in a cardiology practice, but I'm going to emphasize the focus on heart failure. Now, I don't know if you heard my talk last night. It was a little bit more extensive, and we went through the nuts and bolts of how we integrate nutrition into the clinical practice. What I want to do today is focus on the pathophysiology of heart failure. Now, I attempted to make my talk a little bit on the shorter side, so I'm hoping to leave some room toward the end for questions and answers. I'm going to present some of our clinical data, some of our published data, and then give you a case presentation. I'm a cardiac electrophysiologist. I practice in the medical center in Houston. I've been in practice for over 20 years. I'm a director of Montgomery Heart and Wellness and JAM Institute. So I have a dual purpose. In the daytime, I do the typical allopathic medicine, admit patients to the hospital for invasive procedures. An electrophysiologist deals with electrical rhythm disorders of the heart. In my earlier days, I implanted defibrillators, pacemakers, did electrical ablations, did coronary angiogram, and the like. I still do some of those things. Most of the time, I send it to a colleague to do them for me. I focus more on nutrition and wellness and try to prevent the need for those services in the daytime. I want to start off with this little story I often give, a tale of two cities. We have Goliath here, and this is the Texas Medical Center. How many of you have been to Houston? Oh, yeah. Okay, great. Wonderful tourist city. It's the world's largest medical center. They say Dubai is supposed to be larger. I went and saw Dubai's medical center. I don't think it's larger than this. Anyway, it's very large, and here we are, Houston Cardiac Association. I'm about 4 miles south of there. So I'm right there in the shadows of the world's largest medical center. So we're David and they're Goliath. So if TMC is Goliath, the world's largest medical center, about 54 medicine-related institutions, hospitals, medical schools. They have 3 heart transplant centers. I mean, heart transplant is a very big deal, and most of the time a heart transplant facility is regional. You may have one, say, in Pittsburgh, and then everybody, in Pennsylvania go there or wherever. But we've got 3 heart transplant centers in walking distance in 3 of the major hospitals. The world's largest children's hospital have MD Anderson Cancer, about $20 billion budget. This is an old slide. The budget's probably, much greater than that. And then here we are as David, smallest medical center in the world. We've got 1 building, but we got free parking, so we got that on them. And over 2 dozen smoothies and salads sold. About 100, 120 patients a week, maybe more than that now, and the budget far less than $20 billion. So a sizable difference and quite a contrast. So we'll talk about the contrast in terms of how they do things and how we do things. And let's look at the standard treatment for heart disease. Oftentimes patients come and they see me and it's, well, doc, do I have heart disease? And it's a hard question to answer because heart disease is really a constellation of things. It's a constellation of abnormalities. I call it like an umbrella term of any type of disorder that affects the heart. Someone asked, even the other night, asked me, can somebody, have a sudden cardiac arrest but not have heart disease? And I said, well, you really can. Because sometimes people have electrical disorders of the heart. They may not have atherosclerosis in the coronary arteries, but they may have electrical disorders in the heart. So, heart disease is a constellation of things. And so we have to consider what a normal heart function is before we truly understand what heart disease is. So the heart works like a pump, beats about 100,000 times a day. We tend to think of the heart as 2 hearts. We say you have a right heart and a left heart. So the right side is the venous side. Blood that's returning from the body goes to the right atrium, then the right ventricle, then it goes to the pulmonary arteries, and then the pulmonary circulation. That's where then deoxygenated blood gets oxygenated. So if you think about it as having 2 circulatory systems, you have the right heart, which feeds into the pulmonary circulatory system. That oxygenates the blood. When blood's oxygenated, it goes through that capillary system there. Then it comes out to the left side into the left atrium through the pulmonary veins. Any vessel that sends blood to the heart, by definition, is a vein. If it sends blood away from the heart, by definition, it's an artery. So the pulmonary artery goes away from the heart into the lung, so it's an artery, and then the pulmonary veins go into the heart from the left side. Now we notice normally on the veins, inside the periphery, the veins are deoxygenated and the arteries are oxygenated if we stick in the periphery. But if you go inside the chest, it's the other way around. The veins inside the chest leading to the heart are oxygenated and the arteries are deoxygenated. That's because it's taking blood away from the heart, deoxygenated blood away from the heart to the lungs, then back from the lungs back to the left side of the heart. So left upper chamber, left lower chamber, then out the aorta, which is the main artery leading out to the body, taking oxygenated blood to the body. So it goes around and circulates that way. And so when you think about it, as the heart circulates, if things start to happen, go wrong, like if this side gets weak and flow in this direction gets congested, it backs up into the lungs. And so, people with heart failure get shortness of breath, get what's called pulmonary edema, because that's backflow congestions into the lungs because the left heart's not pumping adequately. And if that persists long enough, that congestion in the lungs back up into the right heart. Flow here goes to the lungs, but if that pressure's too high, it tends to back up here, and this, you get right heart failure also. And then this backs up, and see this inferior vena cava, that backs up, that's why you get swelling in the lower extremities. You can also get congestion in the liver, with a fancy phrase, congestive hepatopathy. It means congestion in the liver due to heart failure. So you can see how if this flow is interrupted, you can have a lot of problems systemically. The heart has its own circulatory system. We call the coronary arteries, the coronary meaning crown. These are the epicardial vessels that sit on the outside of the heart. They're actually buried in an epicardial fat pad, okay, in the pericardium. And then these branch off into thousands, maybe trillions of little microvasculatures that take oxygenated blood to the heart muscle. If you notice, oxygenated blood going out the aorta from the other diagram. So the first organ that the heart feeds is itself. So these branches off, these are the first branches off the aorta. So you get oxygenated blood to the heart muscle. That's important because the heart has to be oxygenated to pump adequately. And so if you're in a car wreck and you start to bleed out, the body's going to shunt blood away from different organs, the kidneys, the gut, the legs, to preferentially send blood to the heart and the brain. And so it needs to do that. Heart has its own electrical system. I said I'm an electrophysiologist. This is where I used to do my work. It's a sinus node, AV node, and the conduction systems. And if you have damage to the heart, such as a heart attack, not only the heart muscle gets weakened, but the heart electrical system gets weakened. So if the electrical system gets scarred up due to inflammation, eat too much baked chicken, then somebody like me have to put a pacemaker if your electrical system degenerates and breaks down. So it has its own electrical system. So how can the heart malfunction? I alluded to it earlier. If the coronary arteries become diseased, then oxygenated flow to the heart muscle becomes impaired, and heart muscle tissue starts to degenerate. Impaired oxygen causes cell death, or at least dysfunction, and dysfunction leads to progressive organ dysfunction and eventually cell death, but it can also have a systemic effect. So coronary artery disease results in poor circulation of blood to the heart muscle. If you have a sudden obstruction of a coronary artery due to a clot forming, so if a blood vessel that's inflamed, and we call it has like a plaque that could rupture, then a blood vessel occludes that artery. It does that suddenly to where you have a sudden shut off of blood flow. We call that a heart attack. And you see oxygenation to the heart muscle is suddenly cut off and that tissue dies. Valvular disease, you can have, here's a normal looking valve, but you can have scarring around the blood by the valves. When I look at echoes and I read them every day, we see inflammation around valves on a regular basis. I was asked earlier about coronary calcium scoring. Calcification is part of the progression of inflammation. So tissue gets inflamed and damaged, and over time, you have calcium formation along the tissue. So valves, just like the coronary arteries, can become scarred, inflamed. You have calcification. This valve opens and closes normally. This one doesn't, open normally. This one may not open normally or close normally. So if a valve doesn't open normally, we call it stenosis. So blood flow going across that valve goes across with increased resistance of flow. Anytime there's increased resistance of flow, the heart has to work harder. And so over time, the heart gets weaker as a result of the valves not opening normally. If you have leaking, again, the blood that's ejected from a chamber goes back and the heart's working extra, and so that can lead to dysfunction as well. Electrical diseases, abnormal slow conduction, abnormal fast conduction, electrical disorder. This is a picture of, I don't know if you look at ER, some of those TV shows, medical TV shows, but this is not normal. So if your heart goes into this sine wave, this is called sudden cardiac death. It's polymorphic VT. So you need to have a defibrillator around if something like this happens to shock them out. If you're not, they'll die unless they spontaneously terminate, and sometimes it can spontaneously terminate. So these are some simple, basic areas, mechanisms by which the heart can malfunction. You can have primary heart muscle disease. Systemic illnesses can lead to heart muscle dysfunction. And the common pathway is inflammation. Typically, if there's a local mechanism or a systemic process, it's typically due to an inflammatory process. An inflammatory process in the coronary arteries can lead to a heart attack. An inflammatory process in the myocardium, the heart muscle itself, can lead to weakening of the heart muscle. And so inflammation is usually the common pathway. Now, it's not a rare problem. We have different names for heart failure. You may have heard of diastolic heart failure, systolic heart failure, or a combination. Diastolic heart failure is when the heart squeezes normally, but it's too stiff to relax. Heart function is all about flow. And so flow is cardiac output. And we're going to go over some of these terms a little bit later. It's going to be a test at the end, so make sure you take good notes. Think of the heart chamber. And let's say the heart chamber normally can take in a full liter of fluid. So it relaxes enough to take in a full liter, and it squeezes about 65%, let's say 60%, and it squeezes out 600 milliliters each ejection. So take in a liter, squeeze out 600. Take in a liter, squeeze out 600. And so that's an ejection fraction of 60%, whereas pulling in about a liter. Now, let's say, for instance, the heart gets stiff. And so it can still pump at 60%, but instead of taking in a liter, it's so stiff it can only take in 500 milliliters. So instead of squeezing out 600 milliliters, it's only squeezing out 300 milliliters each contraction. So a stiff heart, even though the ejection fraction, the EF, you may have heard that phrase before, is normal, the relaxation is abnormal. So it doesn't fill up enough volume. So the cardiac output, which is the amount of volume it circulates per unit of time, is cut in half. So diastolic heart failure can be very effective. In fact, the most common form of heart failure is diastolic heart failure. Most people who have systolic have both systolic and diastolic heart failure. But the impaired relaxation, the inability for the heart to fill with volume, is a very common cause of heart failure. So we may do an echo, say, or your ejection fraction looks normal, but you have diastolic dysfunction. And what happens is these people are tired, they're weak, because their circulation is impaired. Systolic dysfunction, the heart is weak, so like that same example, the liter, if it beats out 60%, it sends out 600 mLs. But we'll say if the EF drops to 30%, so it can fill up a liter, but it only ejects 300 mLs. So then the cardiac output again drops by half. So that's two mechanisms by which you can get congestive heart failure. So like I said, here's a test quiz. If you get these right, you don't have to memorize the periodic table. So ejection fraction, that's the percentage of blood that's ejected from the heart each time it beats. Stroke volume is the volume of blood, the amount of blood that's ejected. So ejection fraction is percentage. It's the portion of what's in the chamber. So I gave you one example. The starting volume is a liter. Ejection fraction is 60%. It squeezes out 600 milliliters. So the ejection fraction there would be 60%. Okay, the stroke volume there would be 600 milliliters. Okay, now I gave you an example where the ejection fraction could stay the same. So if the diastolic filling drops from 1 liter to 500 milliliters, but the ejection fraction stays at 60%, guess what? The stroke volume can drop by half because it's the amount of volume. So if the amount of filling volume is less, it affects the stroke volume. Vascular resistance is the amount of resistance of blood flow in the blood vessels. Cardiac output's amount of circulation each time, so how many liters the body circulates per minute of time. And these things are important because it enables your body to circulate. How good your circulation is determines how well you digest your food, whether you remember your keys, whether you have energy to get up and go to the bathroom. I have patients come in with congestive heart failure symptoms. They're not short of breath. They have loss of appetite. They feel fatigue. They have some memory loss, etc. So poor circulation affects you in many different ways, and it's not just shortness of breath that you may sense. And the heart size, bigger is not necessarily better. Some people say I have a big heart, but that's another story. Heart failure, about 5.7 million adults in the United States. It's very expensive. This is probably more like 40, 50 billion now. It's the most expensive, disease state that we have. And it's underlying #1 cause of death. So how does Goliath deal with this? Well, Goliath has a lot of great treatments. We have a lot of pills for you, a lot of pretty colors. And so the pharmacotherapy for heart failure, we do things to affect circulation. So what are the things that have an adverse effect on the heart? Well, if the heart muscle is not strong enough to contract, then we need to do something maybe to make it stronger. So there's some medication we give intravenously that can cause the heart to contract more strongly. There's a drug called milrinone. There's an intravenous form of milrinone, and it improves contractility. I have a patient right now who's flying down to a facility. He's on a milrinone pump. We put these guys on a milrinone pump if they're near end-stage heart failure. And milrinone is a good drug, can cause the heart contract. The concern is that when they created an oral form of milrinone, and they thought, well, maybe if we use the oral form of milrinone, this can help patients. And they did a study, and they compared oral milrinone to placebo, and the people in placebo did better than the milrinone group. So we found that milrinone killed patients, which is not good. We haven't tested the IV form yet. So the oral form kills you, but the IV form we haven't tested, so I'm not sure what effect that may have. But there are a lot of drugs. So there are drugs that vasodilate. So because constriction is a common mechanism of heart failure. So when circulation drops, the kidneys get less flow. When the kidneys get less flow, they send signals to the body to say, constrict the blood vessels because we're in shock. And so when the blood vessels are constricted, that puts even more stress on the heart. So we have to give you medication to dilate the blood vessels. Sometimes the heart's beating too fast or too slow. We have to give heart medications to slow the heart rate down. Beta blockers are beneficial in terms of not only controlling heart rate and to some extent, a small extent, arrhythmias, but it also improves cardiac function by helping the heart to relax. So there are a lot of medications that actually do pretty well. ACE inhibitors, angiotensin receptor blockers, cause the blood vessels to dilate. So these medicines have been shown to be very effective over the years in treating congestive heart failure. If you have coronary artery disease, you may have multivessel coronary artery disease that's impairing flow to the heart muscle. We have treatments for that. We do angioplasty. There's coronary bypass surgery that's in some cases can be helpful. Certainly primarily for treatment of angina, but in some cases it can help people with heart failure. If you have heart failure, you may be at risk for sudden death. Patients with congestive heart failure die of one of two ways. They die of progressive pump failure, so that means your circulation progressively slows until your organs slowly, progressively fail and fail and fail, and then you die. They give liver failure, kidney failure, and they eventually just die kind of a slow, miserable death. The other way they die is sudden death. So they may die in their sleep or just drop dead, something like that. We have pretty good treatment for sudden death. In fact, defibrillator implants, when I was doing my fellowship, I started my EP fellowship back in '94. And at that time, the defibrillators were just becoming, they really weren't fully commercially available. They were really experimental at the time. In fact, we did a lot of implants experimental. And at that time, we didn't know, who really needed or how to decipher. We didn't have all the data. So you had to die suddenly twice in order to get a defibrillator, because you have to open your chest up and they sew the leads on your heart, and I was involved in those things. And so then we got a little bit better. Then you only had to die once, and then we would do electrical studies on the heart. So if you had a weak heart, if you had heart attacks, we do what's called an EP study. So we'd put catheters, electrical catheters on the wire, and I'd pace your heart and stimulate it in a certain way. And if I can put you in sudden death and shock you out, then we would give you a defibrillator then. So for a long part of my career, my career was putting people to death and shocking them out and implanting devices. And seriously, that was what we did. And then learned more to where if patients had asymptomatic arrhythmias and they were likely at risk for sudden death. But then one day they did a study. We would try to figure out who was at risk for sudden death. And we did all sorts of testing, arrhythmias, or T-wave alternans. But the one underlying theme was heart failure. Heart failure was the underlying theme that we knew that it was an underlying theme for risk for sudden death. So someone did a study one year where they got thousands of patients, one group, and they were asymptomatic for arrhythmias. And they gave one group a defibrillator plus usual care, and the other group just got usual care. And they followed them over time, and they saw a survival benefit in the group of defibrillator. So we found out that if you had an ejection fraction less than 35%, that by itself was enough of a risk of sudden death to where we would implant these devices. So now, if you have an ejection fraction less than 35% and it's chronic, and you're on optimal medical therapy, then your doctor would probably recommend a defibrillator. While you're waiting on the defibrillator, you can wear what's called a life vest. So oftentimes patients may have heart attacks, and the heart's weak as a result of a heart attack, and they don't know whether your heart's going to get stronger or not. You may wear a life vest for a temporary period of time until you're waiting for the heart to recover and determine whether you need a defibrillator. But the defibrillators work very well. Implanted device is a very simple procedure to do, and it's your 911. Okay, I've had lots of patients I've treated over the years that, they come and I interrogate the device, say, oh, you had a sudden death episode, 2 months ago. And they didn't know it. I mean, they would have died in their sleep. The device detected, shocked them out, and they just had sweet dreams. There are more advanced therapies, heart transplant. This is an LVAD, so if you're at near end stage heart failure and maybe you're waiting on a transplant, you can have this LVAD stands left ventricular assist device. So this is a mechanical pump. You have to carry your batteries around with you. The battery life is about 4 hours, so you got to keep extra batteries. If you run out of batteries, your pump stops and you drop dead. So you have to stay with this. I have an LVAD patient now that we put on a raw detox, and we're looking to wean him off the LVAD. So you may come off the LVAD in about 6 months. So you can reverse it from this point if you do some of the right things and if you're in the right condition. So that's Goliath's approach. What is David's approach? Well, we have a new approach to thinking about disease. So first of all, if you're going to treat disease differently, you have to think about disease differently. And I get questions about, well, does your program help disease X? Does your program help disease Y? Does your program help disease whatever? And in medicine, what we've done, either convenient or inconvenient, we've isolated these disease states, and really they're kind of a common pathway. Now I put here poor nutrition, but in essence what happens is that the body becomes biochemically imbalanced or physiologically imbalanced, and when things are biochemically imbalanced, then your body starts to compensate in certain ways. So if you become biochemically imbalanced, you may have DNA mutations, may lead to cancer and more inflammation, that may lead to arthritis or heart disease. And so really these diseases are all a common disease, a common mechanism. Inflammation is very common to just about all of them, but there are other common biochemical and physiological imbalances that can occur that can relate to any one of these diseases. And when we give them different labels, the different labels are just due to a different clinical manifestation. So if this person has a fast heart rate and turned purple, I say, okay, you got fast heart rate purple disease. And this person has a slow heart rate and turned green, I say you got slow heart rate and green disease. But they have the same common pathway. It's just that I give them different labels because they're different clinical manifestations. So that's where the differences that we deal with come into play. And the question that's burning your minds and your hearts is, can food be used to reverse heart failure? Is that what y'all wanted to figure out? Not really. It's inflammation and vascular dysfunction. I think I alluded to this quite a bit in the first part of the discussion. Inflammation is a complex biological response of the body tissues to harmful stimuli. We've all had injuries, maybe riding a bike, fall off a tree, whatever. Maybe you scrape your arm, okay? That's an injury. You scrape your arm, what happens? It gets swollen, it becomes painful, red. That's an inflammatory response. Why? You had tissue damage. Maybe capillaries are broken, maybe microvessels are broken or damaged. And so the body says, hey, we've got damage. There's a foreign process. So they send out, it's like a fire breaking out. So if a fire breaks out in this building, they'll call, a fire alarm will go off, and then the fire department will come. And so let's say if it's a very large fire, there may be a 5 alarm, so maybe call 5 fire trucks. Maybe it's a small fire, it's called 1 fire truck. But you'll get an alarm and that'll trigger a response to a rescue system. And that's what inflammation is. You get an injury somewhere, and there's a trigger to response for a rescue system. The rescue system is your immune system. So there are white blood cells and other inflammatory cells, immune cells that go to that site. And there are a lot of biochemical reactions that take place. And then it's almost like a battle or war that breaks out. If the firemen break in here and let's say there's a big fire, they'll knock doors down and they'll spray water. They'll create damage trying to treat the fire. Same thing here. There's tissue damage that occurs here in this immune response. If you get an exaggerated response, then there's exaggerated damage. Now, what if there are fake alarms, fire alarms all the time? What if at this building, every day there was a fire alarm and the firemen come in here, they're breaking the walls down, they're spraying the place down, breaking the walls down. This place will become damaged over time. And so that's what happens in the body in certain parts, like your joints, inflammation all the time. There's inflammatory response. So there's a constant smoldering inflammatory process that's causing damage over time. So that scarring and wearing and tear is what leads to the damage, and that leads to calcification in a chronic situation or the like. Vascular dysfunction, in part due to inflammation, but impaired arterial venous structure function, poor circulation. This is in part due to inflammation. And so you see here a normal coronary artery, and over time, see the disease starts in the blood vessel wall. Now we know from autopsy studies, you see this here? What percent of 14, 16-year-olds have that based on autopsy studies? Right here. About 65%. 65%. They did autopsy studies on the male soldiers in the Korean War, and they looked at it. About 77, 78% of them had gross plaque. So gross plaque is somewhere around here, at least around here, where you can see it visually. And so that's at the age of 14 to 16, and 22, we're almost at 80%. So guess what the percentage is at 30, 40, and 50 years old? Virtually universal, if you're on the standard American diet. This is something that's normal. So when I deal with patients, they all come in with this. So it's a matter of how much they have and how it's manifesting, but they all pretty much have this. We've seen it as early as birth, actually. So food and inflammation, it's really simple. There are foods that we know that cause inflammation and foods that we know that work to limit inflammation. And so we like to eliminate this first and foremost. The first thing, if a building's on fire, it's good to spray water on it, but you need to stop spraying gasoline on it, okay? So if I got a building on fire and I got somebody spraying gasoline and somebody spraying water or somebody trying to get the water hose, the first thing I'm gonna do is say, wait, why don't we stop spraying gasoline on the fire? And when we're eating food like this and we have underlying inflammation, then it's like spraying gasoline on the fire. So you need to stop this first. That's what I emphasize first and foremost. I don't talk too much about this until I get patients to stop eating this. In fact, it's not hard to get people to eat in this area. It's hard to get them to stop eating in this area. Biggest junk food eater in the world, every now and then will allow a piece of broccoli to slip past their lips. But they have a hard time getting off of this stuff. Back to hemodynamics. Y'all ready for your test? Ejection fraction, y'all remember that? Stroke volume, vascular resistance, cardiac output, heart size. The reason I went through that because I'm going to show you some data and I'm going to show you what effects plant foods have on these hemodynamic parameters. We did a study, and we've been doing raw detox boot camp classes for over 10 years. We've got thousands of patients we've studied and we've looked at. This is one of the earlier groups. We took 15 adults, put them on a 4-week nutritional detox. Now, we do raw fruits and vegetables only. You guys ate at the lunches and all, and it's very nice, healthy, vegan food. We actually take it to the next level. It's 4 weeks of grass and water. So it's all raw detox, and we do it on purpose, not just because I'm evil. I have other ways of displaying that characteristic, but this is because we want them to change their taste buds, and you have to do it in a rapid way. So moderation is nice. You can kind of take baby steps, but you just don't get anywhere, okay? And if you're really sick and you have heart failure, we don't have time to take baby steps. And if somebody has a cardiac arrest and I'm in the hospital, they want me to take baby steps, you want me to run and do something fast. I need to do something drastic. So when people are this sick, we need to do something drastic. So we measure blood pressure and all that stuff with a special machine called a BioZ. The name's not that important, but this machine is nice because it gives us hemodynamic data very similar to what I can do if I float a Swan-Ganz catheter in a patient's heart. So it tells me stroke volume, it tells me vascular resistance, it gives me cardiac output. So it gives you a lot of detailed information, and we can do that in our office non-invasively. So we gave them a 4-week boot camp detox class. It wasn't exercise, just raw fruits and vegetables. And we gave them lectures, shopping rounds, gave them a lot of support to understand why they're eating what they're eating. They eat raw, they come in a week, they complain. We jump their case, and then they go the next week and eat more. What did we find? Now, this is a busy slide. I'm going to show you this, but systemic vascular resistance, remember that? That's the component that measures the amount of resistance to flow. Remember, cardiac output needs flow. You want arteries to open up so flow is natural. When arteries are constricted, vascular resistance goes up. That's not good. So resistance is high, flow is low. So we started off with a vascular resistance about 1648, went down about 26%. I'm going to show you some slides of that. So vascular resistance decrease, and we're getting ready to submit this for publication, actually. Their volume increased, so thoracic, so they became more hydrated. We saw the heart rate, which was higher. Remember, if you're squeezing out less blood per heartbeat, you have to beat faster to squeeze out. So if your stroke volume goes up, the heartbeat goes down because it doesn't have to beat as fast to keep the circulation up. So we saw that go down. Let me give you something less size. So vascular resistance, 1648 went down. There's about 26%. This is just in 4 weeks, by the way. And this is just on raw fruits and vegetables only. Okay? Cardiac output went up. Now, this was not statistically significant. It was very close, though. But the vascular resistance was. Stroke volume improved. This was statistically significant. Thoracic fluid content, so they became more hydrated. There's more filling, more volume, filling the left heart, filling the right heart, and therefore filling the left heart. Pulse rate went down. The heart did not have to work as hard, didn't have to beat as fast. So an overview, cardiac output trended toward increased, stroke volume increased, vascular resistance went down, which is good. Thoracic fluid content, preload went up, pulse rate went down, systolic and diastolic blood pressure went down. Of course, the weight and waist circumference also went down, which was significant. And here's a graph sort of showing that. So stroke volume went up, cardiac output went up, thoracic fluid content, filling pressure went up, and vascular resistance went down, blood pressure, and all these things went down. So it showed very wonderful effects in terms of improving circulation and improving heart function, et cetera. So we started to get a little bit fancier this time. So we did a case series of 3 patients, and we did cardiac MRIs. And MRIs gives you very detailed information about any tissue that you're measuring. And so with the MRI, we were able to look at how big the heart was. We were able to look at the heart squeeze. We can measure all of those hemodynamic parameters, and we can get a before and after. So we had a series of 3 subjects, and we recently published this. 3 subjects that had an MRI before, and then we put them on a plant-based detox diet. And for about an average of 78 days, we followed and repeated the MRI, and this is what we found. We saw where the EF went up 22%. They were put on food levels 0 to 4A for about 6 weeks, baseline and follow-up MRI. What do we find? Same thing. Ejection fraction went up, cardiac output, stroke volume went up, LV mass. So the hearts got smaller. Okay, the thickening of the heart started to decrease. Diastolic volume went down, systolic volume went down. In other words, the heart got smaller and stronger, essentially is what we saw there. We need to do more studies, but EF went from 22% to 42%. Remember I told you that if your EF is below 35%, you need a defibrillator? So they went from needing a defibrillator on average to not needing a defibrillator. That's a big deal. So from an individual standpoint, not having to have a device in, from a global standpoint, you know, these devices are close to $20,000 each, so Medicare is going to smile if they don't need it. And we'll all smile because we're paying the taxes for that. But anyway, so these are the findings we saw: ejection fraction improved, stroke volume, cardiac output, LV mass, diastolic volume, et cetera. Here's an example of one of the patients, a 46-year-old lady. Now, if you've heard my talks before, you may have heard me talk about her. She's a 46-year-old lady working in the oil and gas industry. She went to a health fair and, you know, did health fair type stuff, vitals, and they pricked her finger, and she was told that, you know, she had some health issues, and so she felt that, you know, she was overweight. She wanted to, you know, improve her health, so she decided to go get gastric bypass. So she went to see the surgeon, and they did an EKG, it was abnormal. They said, well, you can't, do that, go see a cardiologist. So she came to see us, and we saw her, questionable prediabetes, high blood pressure. She had chest discomfort that woke her from sleep, shortness of breath, exertion. She was fatigued, which is a common, oftentimes women will have just fatigue alone. They won't have any chest discomfort or anything. And we did EKG, it was abnormal. I did an echo, and our EF was 20 to 25%. Okay, the MRI showed 24%. What we did is that we put her on the detox right away. I took her to the cath lab, and I did a coronary angiogram. That's my catheter there. And this is the dye. The dark part is where this opening flows. See that little narrowing there? That's called a stenosis. And this vessel here is what we call the left anterior descending artery. Y'all heard of the widowmaker? This is a widowmaker. But in her case, a potential widower maker. So it's a very tight narrowing. Now, I won't bore you with the details, but the long story short is this location, even though it's one vessel, is not a good location for a stent. Because if you put a stent here, you push plaque into the left main, and you could kill her. Notice also, see this vessel here? See, it's very close to the same size of my catheter. Keep that in mind. She went on the raw detox, and we put her on for about 5.5 months, and this is what we see after. Now, this stenosis went away. See how this left main is significantly bigger than the catheter. Same catheter size, et cetera. So you got the before, and you have the after. Okay? So we did a before and after MRI, and notice that this is before, the ejection fraction 20%. See how the heart, it's not really contracting. Look at the walls, it's not thickening very well. This wall is thickening a little bit, but it's more rocking than anything compared to here. See how that's thickening there? So EF for 24% to 50%. These are measured, it's quantified by the MRI analysis. So very significant coronary improvement. Now, the amount of improvement in her coronary flow probably wasn't totally explained by fixing that LAD lesion. So she probably had lots of small vessels that opened up as well. We saw the left main open up some as well. But we saw that she did quite well, and she was one of the 3 patients in the series that I presented to you. So she's 46, but how old is too old? I mean, oftentimes people will say, well, he's 85 and he's lived this life, let him eat what he wants or whatever the case is. I think it's more torture for older people to feed them bad food because it makes the arthritis worse, it makes their heart failure worse, the liver worse, it makes their life more miserable. I mean, he's 85, maybe he'll live to 90, want to live 5 years in misery? So it's actually never too old. And in this case, here's one of my patients. She came to us when she was 101. She had heart failure, and she wanted the detox, and we reduced the medication. Here she is at the ripe young age of 103. Her birthday is actually 1 day before mine, so we kind of said hello together. But anyway, it's never too old. We've detoxed patients in their 80s and their 90s. We have a 90-year-old, a lady who's like 93, 94. She came at 89. She did a raw detox. She's a raw vegan now. She negotiated a 50% discount in my restaurant, and so she's in there shopping all the time. But she drives independently. She takes her grandkids around, and she has a very high quality of life. And so it's never too late. So we'll open the floor for questions, answers, smart remarks, personal attacks, whatever. We'll start in the back. Great question. So the question is, what about supplements? And specifically, if a woman who's taking calcium supplements, what do you do for her? Here's my take on supplements in general. We use supplements only in a targeted fashion. I'm not a fan of just sort of randomly giving supplements. Oftentimes you have to take a vitamin D supplement because we're indoors. Oftentimes you have to take a B12 supplement because we live in a sanitary environment and our microbiome is not optimal. And we may have to take other supplements. I mean, patients with arrhythmias who are low in magnesium may have to have supplementation for that. What I do in my practice is the following. When we see patients, we do special tests. It's a micronutrient test. So it's a combination blood and urine test that we get. And it looks for not only serum vitamins and mineral deficiencies, but also look at intracellular. So it gives us an idea, not that it's perfect, but it gives us an idea as to whether that person has intracellular or serum deficiencies in certain minerals, and then we'll target those. Sometimes you may have to give intravenous infusion of certain vitamins and minerals, depending on the patient's clinical scenario and depending on what we find. So from a supplement standpoint, we use a more targeted fashion. I'm not a big fan of supplementing calcium. Okay, you get calcium from greens and certain seeds have calcium. So you get calcium from a lot of foods that are plant foods, and all these minerals are found in plant foods. We just use supplementation in a semi-urgent fashion. So if someone's having lots of arrhythmias and the magnesium very low, I'll give them intravenous magnesium or oral magnesium, while at the same time giving them foods that's rich in magnesium. So I like to use the whole food as a primary source. And when I do give supplementation, I may do it for 3 or 6 months and recheck and then convert them just foods. But that's my take on supplementation. Well, there's some data I remember reading showing that women who take calcium supplementation have higher incidence of heart attacks. So the mechanism, could be varied. But supplements, by definition, are not foods. And so if you're consuming an isolated nutrient, one, it's not in its natural state, so it's going to work in a different mechanism. The body sees it differently. That's one. Two, many supplements have other carrier molecules and trace molecules, preservatives, dyes. Some have animal protein that may be harmful. So you're talking about an isolated nutrient, even in its purest form, is not ideal because, foods, if you listen to Colin Campbell's lecture, the body doesn't, when you eat broccoli or, a potato or kale, it says, well, here comes broccoli, or here comes a potato, here comes kale. A baked chicken, here comes trouble. But the bottom line is that it recognizes food as food, not says, oh, here comes a carb or whatever the case is. Okay? Yes, sir. And I'm going to work my way down. So what are my thoughts on PVCs? PVC stands for preventricular contractions. Those are arrhythmias we look at. And PVCs originate from the lower chamber. So if you line up infinitely many PVCs in a row, you get VTAC if they're very close together. So my thinking of PVCs they are a sign of an underlying abnormality. What is that abnormality? It could be scarring in the heart. It could be electrolyte abnormality. Oftentimes the potassium, magnesium may be low. By simply correcting those things, the PVCs could be suppressed. Some of my electrophysiology colleagues like to go in and ablate the PVCs, which I guess that's okay. Medicare pays for it, I guess. But I think PVCs are a sign of an imbalance, and you need to correct the imbalance. So look for the cause. It's sort of like if we smell smoke, right? We sort of, okay, there's smoke. Let's look for the source, right? It could be a fire, it could be electrical disorder. We don't just sort of fan the area and say, okay, we got rid of the smoke. We can all burn down. So you want to look for the source. And so the PVCs are more, I like to think of them more as a sign of an underlying problem that you look for. And then you address that, and then the PVCs go away. I think yes, sir. So the question is about atrial fibrillation. The atrial fibrillation is not a PVC. It originates in the atrium. The PVC originates in the ventricle. Atrial fibrillation is the most common arrhythmia we have. And it's really an electrical disarray of the atria. Remember I talked about inflammation. Well, atrial fibrillation is primarily triggered by inflammation. We also know in the pulmonary veins, they're conduction tissue like electrical signals. And back maybe, 16 years ago, I was doing AFib ablation. So I'd put like 2 holes in the heart, put my catheter across the right heart to the left heart, fish around to the pulmonary veins, and put burns around those pulmonary veins to isolate them to prevent those signals from coming across. The problem is all the patients who had AFib had recurrence of AFib because it's not just a one etiology. It's really a constellation of problems. And really it's inflammation in the atrium, remodeling, stretching, scarring. And so when you have stretching and scarring in the atrium, that electrical wiring gets damaged. And so when the electrical wavefront comes down, because there's scar, it's sort of like having potholes on the street, right? So if you're driving on the freeway, the street's smooth. But then after a while, you get potholes and you get and then you got to move around to dodge the potholes. So electrical activity does that. So when it has to dodge a pothole or scar patch, it then makes a little circuit. And so you get a lot of these little mini circuits, so then the arrhythmia occurs. It's a constellation of inflammatory process. So now, can a plant-based diet help? We have lots of treatment for atrial fibrillation. What we do know in the medical literature is that probably the most successful treatment is diet and exercise. That's in the medical, that's not even plant-based diet. That's just like any random old diet that helps you lose weight or do whatever. I have some data showing raw detox decreasing AFib burden. Now, in the study we're planning to do for our heart failure page, we're going to do before and after heart monitorings. We're going to look at atrial and ventricular arrhythmia burden and see if we see a reduction in that. Anecdotally, I'll tell you I've seen that, but I can't say that there's scientific studies because I'm not aware of a study looking at a plant-based diet's effect on AFib directly. But I suspect that it does, based on what I've seen clinically. Yes, sir. So the question is, the issue of getting your heart rate up with age, with exercise, so the thought process is, as you get older, it's harder to get the heart rate up as you age. Aging is more of a progression of degeneration over time. There's a disease state called Levs disease or Lenegre's disease. There are two pathologists who pretty much describe the same thing, which is a primary degeneration of the conduction system. And I say primary, it's due to inflammation in the conduction system, so there's a slowing. So oftentimes, older patients will have conduction system abnormalities. So the electrical system starts with a sinus node, and conduction goes down to the ventricle. Shouldn't ask an electrical question to electrophysiologists. They really get bored to death. You start off, the sinus node is your God-given pacemaker. So that tissue initiates electrical activity. So let's say, for instance, you're a pacemaker, I'm standing here and I'm talking and that type of thing, and I'm nervous about the next question you're going to ask. And so my pacemaker sends out signals faster because my brain says things are faster. Maybe if a bear runs through the door or something like that, it goes even higher because I'm nervous and my brain sends signal to the sinus node saying, okay, we got to go. And so it'll ramp up the activity and ramp it down. Then that electrical activity then goes through, now this is oversimplification, but there's a complex mesh of conduction pathways that send signal from here down to what's called the AV node. And then this serves as a filter. It slows conduction down because sometimes you go into atrial fibrillation, like you mentioned, you don't want to go into ventricular fibrillation, you die suddenly because you know that this tissue can become abnormally fast. So this filters a certain amount of activity through, and then it goes down the conduction system here. Now, what happens is as you age, you can get scarring. Chronic wear and tear. Inflammation can affect the conduction system. So let's say you have inflammation affects the sinus node, and maybe you develop a scar right around this tissue here. So if you develop a scar there, the electrical activity that goes out has a hard time getting across that scar barrier. And so it may be slower than normal. So this slow progression of heart rate or conduction abnormalities in older people is likely to be due to progressive inflammation in the heart. So they may not have a heart attack or any other condition, but if they're eating the standard American diet, not getting sunshine and doing horrible things to their body, that's wear and tear. And so as you get older, the conduction system wears out, and that's probably what you're dealing with in that situation. So, I mean, it's a slight simplification, but generally speaking, yes, if you're able to get a heart rate up as you need to and keep it up, that's a good sign. Now, resting, you want to have a slower resting heart rate. So let's say you're exercising on a regular basis. You like for your heart rate to be around really 60 or not higher than 70 is my preference. But certainly if it's below 70, resting heart rate, that's good without medication or the like. Now, you have to distinguish between pathology or physiology. Some people who are older, for what I just described, may have a heart rate in the 40s, not because they're physically fit. I mean, if there's a couch potato sitting there eating potato chips, the heart rate's 40 and he's kind of tired every time he goes to the refrigerator, he probably has conduction system disease. But you have somebody else who runs marathons, works out, et cetera, and their heart rate's 50. Well, that's physiological bradycardia, so it's a difference. So there's a cross between a healthy bradycardia, a healthy slow heart rate, and an unhealthy one. And another question here and then here. So the question is, there's a person with one carotid artery partially blocked, but he's physically fit, he's a runner, so is there a chance for other vessels to be damaged? Is that correct? The answer is no. It's not necessarily a problem in the heart function. Atherosclerosis, or disease of the blood vessels, if it's anywhere, it's likely everywhere. So it's really a systemic disease. So the process that causes atherosclerosis is whatever that process is. The heart just happens to be affected just like other blood vessel organs are. So for instance, somebody who gets kidney failure, progressive, there may be a diabetic hypertension, their kidneys start to wear out. A kidney is a vascular structure. And so kidney disease is like a vascular disease. It's atherosclerosis in the kidneys. And so the same thing is going on there, it's going on in the heart. They just may have a propensity for the kidneys more so than the heart. He may have a propensity for the carotid. Some people have a propensity for vascular disease to advance faster in the brain. But it's usually systemic. It's just that one organ may be affected more extensively or more rapidly than another. So when people come in and say, I'm vegan, I'm plant-based, I don't know what that means. I have to say, what are you eating? But I'm not being critical, I'm just saying. Because, the phrase, and that's why in my lecture last night, if you heard it, I was very specific on precision in terms of what you eat, especially when we talk about clinical medicine in terms of manipulating foods to allow your body to get better. You, then the cameraman. Yes, sir. That's a good question. So the question is 2 stents 4 years ago, and you're taking an aspirin. So if you go vegan, can you get off the aspirin? I don't know. It depends. So it depends on what your diet is. It depends on how your body responds to the nutritional changes you make. The benefits of an aspirin are primarily twofold. It's an antiplatelet effect and it's an anti-inflammatory effect. The anti-inflammatory effect may be the more important role, but there's an antiplatelet effect that goes with it. In the chronic setting, the anti-inflammatory effect is probably more important. If you go on a plant-based diet, some of the data I showed you, inflammation goes down. I showed you data last night, especially raw. Now, if you tell me you'll be a raw vegan, I'm going to go grass and water for the rest of them, and then maybe that you're in good shape. But no, the point is that it's possible. It just depends. Because people on a vegan diet, I could put you on a vegan diet and make you sicker than somebody who's on barbecue and Philly cheesesteaks or something. So you can eat a very bad vegan diet, so you just have to be careful. So the answer is it's possible. You just have to follow up with your doctor and see how your blood markers change, and yes, it's possible. Yeah, so the question is, what's the issue with supplements, but then certain foods are fortified with vitamins? I tend not to like foods that are fortified. Supplements are isolated nutrients, even if they're added to whole foods. So the food is the food, that's the ideal way to eat it. Plant-based foods in a natural state, that's going to be the ideal way to eat it. I don't want to say there's a downside or upside. Now, when I say raw, we're using it in a therapeutic sense. So there's a way of manipulating. So people with advanced disease, have to nourish their bodies in a certain way. You may be in an ICU on a ventilator, so you may have to consume foods in a certain way. Raw is certainly better, and there's evidence that show raw is better when you're detox and cleansing. Jenkins have data on that. And we have some data showing that, especially in a therapeutic setting, raw is more effective.